Thank you for submitting your questions on the Q&A tab throughout the session, and please continue to do so. We will do our best to get to as many questions as possible. So I would like to welcome our expert group of panelists, Drs. Pearl, Desai, Lee, and Richie, and we are going to talk about AML cases, except there's only one slide. So you will see that what I'm going to do is try to talk about a basics of a case and then add and subtract things so that we can hopefully very quickly go through a whole bunch of scenarios for a newly diagnosed AML patient. So this lady is 68 and she has mild COPD, a one vessel CABG 10 years ago, but she's asymptomatic and has a normal EF. Newly diagnosed AML, and the white count is 23,000 with a hemoglobin of 7 and platelets of 40,000. And that's all I'm telling you. So Sasha, what do you want to know next and why?
I want to know if this is a therapy-related leukemia and you've withheld that information that she was treated for breast cancer in the past. I'd love to know her karyotype. But that would be the first thing I'd want to know. And is it a core binding factor leukemia or an NPM1 mutant?
Okay. So, I mean, I think what you're getting at here is we're missing a lot of information, right? So all I've given you back is the white count, and you're talking about mutational data and cytogenetic data. So let's go through that. If this is, so it's a 68-year-old lady, if this is actually a core binding factor AML, what is likely to be the treatment for that?
Well, it sort of depends, but as much as possible, I want this to be the youngest, fittest 68-year-old, because if she's got core binding factor leukemia, I'm going to want to treat her very aggressively because you could potentially cure her. If you look at older patients, you can say it's favorable to have core binding factor leukemia, but it's still not great. But yet those patients can do better than almost anybody else if you treat them intensively. So you want to find a reason to say, if we're going to give intensive therapy, there's a reason why, because we can potentially cure.
So Ellen, I think this is an area that you often deal with. So you have somebody who's 68, right? That's right on the edge of somebody who's in perfect shape, but she does have some comorbidities. What other information about these comorbidities, what should doctors be looking for to try to figure out whether we are or are not pursuing a so-called intensive versus less intensive route?
Well, it's not just comorbidities, but it's the functional status of the patient. So you can have a 68-year-old with COPD who might be obese, sitting in a chair, can't really walk from the TV to the bathroom without some difficulty and back. You also can have a 68-year-old who's running marathons despite, comorbid problems or being extremely active. Or might be working full time still and be, very actively involved in their life. So it's really, really important, I think, to determine what the functional status of your patient is, how much can they do for themselves, and also what kind of caregiver they have. So if this is a 68-year-old lady who lives alone in a 6th-floor walk-up with no one to help her, that's really different than a 68-year-old lady who has a husband at home and her daughter lives 2 houses away. So it's really, really important to actually determine the functional status and the support that patient has when you're considering how intensively to treat the patient.
I think so. That 23,000 white count is going to be, I think, very important, right? Because that may result in some additional element of decision making. So let's talk about that, getting back a FLT3. A FLT3 mutation can be present in the setting of a core binding factor disease. It can be present by itself. What about that FLT3? How quickly are we getting those back these days? Pinkel, talk about sending a FLT3 and waiting or not waiting for that result.
So, waiting for FLT3 is very, very important and relevant because most of our treatments will diverge a lot depending on the presence of FLT3. And we have a way to now, look at FLT3 through PCR. So usually within 48 hours of sending bone marrow or blood, you can have a FLT3 by PCR that would tell us whether the patient has an ITD, is it a high or a low allele ratio, and then whether a TKD mutation is present. And I think that, and you absolutely have to wait for that before you make any treatment decisions. It's different between core binding factor versus non-core binding factor. Obviously, it's very relevant in the non-core binding factor setting. But anybody who has a higher white cell count, the FLT3 becomes an important test to wait to come back.
My thinking is that sometimes people are kind of looking at the age and looking at an immediate decision of, oh, well, wait a minute, am I using a venetoclax-based regimen on a patient like this, or am I not? And they're kind of looking at the age and the white count and trying to make that decision. And what I'm trying to break down a little bit in the discussion is how not to do that. So we want to get back cytogenetics. We want to urge the laboratory to try to help us out as quickly as possible with core binding factor information via, for example, a FISH test, if that's faster than cytogenetics. We'd like to have a FLT3 back. But I think a lot of our audience may not get that testing back quickly enough. And they're worrying during this conversation that we're talking about things like 24 and 48 hours, and they don't get it back quickly enough. So what about waiting a few days? There seem to be very good data, actually, that for a lot of AML patients, you can hang out for a minute and wait for your data. Sungmin, do you want to talk about that for just a minute, that if the patient is sitting and not extremely ill, what data should we really wait for before we make that first leap?
I mean, I think the cytogenetics and mutation status, you can certainly wait for. FLT3, like Pinkel said, comes back relatively quickly, and cytogenetics and FISH comes back relatively quickly. I think waiting depends on the pace of the white blood cell and how proliferative the patient is. If the patient has had white blood cell of 23,000 for a couple of weeks and it's not likely to go up rapidly, then you can start hydroxyurea and wait for more data, whether inpatient or outpatient. But if the patient's white blood cell was 10,000 yesterday and it's climbing, then perhaps you should act more quickly. So I think decision to treat urgently or not also depends on the pace of the white blood cell and how proliferative it is.
And Sasha, you wanted to know right out of the gate about the therapy-related disease, and I didn't mention anything in the presentation about MDS-related changes or morphology suggesting that. Why did you want to know that?
Well, if this is somebody who you're going to treat intensively, you want to know which regimen to choose. And there are comparative data using liposomal formulation of Ara-C and daunorubicin versus standard that favor using the liposomal formulation in patients with certain demographics, so therapy-related or AML with myelodysplasia-related changes, or a known prior MDS would be the areas where, if you're going to treat intensively, this is actually the age group where survival benefit was seen.
I think that, this case is meant to be hard. And I think that one of the points that I really wanted to emphasize was there's no kind of absolutely obvious path, right? You can have a 68-year-old who is absolutely eligible for an intensive therapy and who is absolutely eligible for a venetoclax-based therapy. And you're going to want to make that distinction somehow. So what if this is a patient with a FLT3 ITD who has a normal karyotype FLT3 ITD without MDS-related changes, and whose COPD and CABG are actually not super relevant, and she's in good shape? Sasha, what are you going to do?
If a person's eligible for a clinical trial of a frontline second-generation TKI with induction and is a fit patient that I'd want to induce and treat intensively, I'd want to put them on a trial. And that's actually where you really want to know this information quickly, because if you know they have a FLT3 mutation, then you know this might be a best therapy for them. And there are trial options open. There are studies of gilteritinib versus midostaurin, studies of crenolanib versus midostaurin, or you could just treat the patient off study with midostaurin. I don't think that that's a problem. We'd just love to know, are the newer drugs any better? But when a trial option is an option for a patient and it's an important question, and there may be a reason to think that a new drug could be better than existing therapy, that's what I'd like to do.
Let me interrupt you for 1 second, because one thing is, if there isn't a trial, okay, and you're not sure about the fitness, maybe she'd do okay, maybe she wouldn't with intensive induction. Is a venetoclax-based induction, venetoclax azacitidine, for example, is that precluded without a FLT3 inhibitor?
No, not in the least. So if you look at the Viali-A data that was just published in the New England Journal, showing the superiority of venetoclax and azacitidine over azacitidine alone, The benefit was seen pretty much across subgroups, including patients with FLT3 mutations, who actually did reasonably well on that study, had a high remission rate. We don't have subgroup analysis for how long the survival was for the FLT3 mutated patients, but I don't know data that says that a FLT3 inhibitor frontline is better than that. And that's actually our standard to give venetoclax azacitidine. And if a patient relapses on it, that's when we'd look at FLT3 inhibitor-based therapy.
Okay. I mean, I think that's an important thing also, that I think people have it in mind that, okay, well, at least I know that if the patient has a FLT3 mutation, they have to get a FLT3 inhibitor. Well, again, there are lots of shades of gray here, and I think that there may or may not be a specific indication here for an inhibitor. Okay, so what if she doesn't have any MDS related changes, and what if she has an IDH mutation? Ellen, what do you think of somebody like this who's, let's say she's in good shape? She could go either way. She could get intensive therapy or non-intensive, but she has an IDH mutation.
And I think that she would be a good clinical trial candidate if she would be eligible for one of the trials looking at either HMAs plus IDH1 and 2 inhibitors in the frontline setting. And I think that would be the way that I would like to treat this patient. If a clinical trial is not available and she is not eligible for a clinical trial, then I think that I, again, would treat her with venetoclax. And, there are patients with IDH mutations actually do fairly well with HMA type therapy. And I think the likelihood is that she could go into remission with that without receiving an IDH inhibitor.
And can she have an IDH mutation with a FLT3 mutation? Sasha, are we going to see that?
Yeah, I have a number of patients where we have to decide what's more important, what should we go after now versus later. So certainly these can overlap.
And some triples are coming, right?
Oh,
so
yeah. And that's the other thing is we don't currently have a frontline triple regimen where we can say this is tested, this is the right way to give it, this is the right dose and the right number of doses. We're still figuring those, I think, important questions out because there could be a lot of myelosuppression putting all of these drugs together in one cocktail. And let's figure that out in a careful setting where we don't hurt patients.
And just one quick question on what do we do? So let's say that she does have a FLT3 mutation and she goes into remission on whatever and then looks great. So is this still a transplant situation for you guys? Because the rest of us are together at Cornell. So what do you guys do at Penn? Are you transplant?
Assuming you mean FLT3 ITD, yeah, we would transplant a patient who was fit for induction, had high-risk genetics, and over age 60-something. It's hard to say almost anything isn't high-risk genetics because survivals are so much lower than in younger patients, even with identical therapy. So yes, if this is somebody fit for induction, we often will say if you're fit for induction and you have donor options, that we should look at transplant in remission. Bearing in mind, how did induction go? Did you sail through it or did you have a lot of complications? Was this easy or was this hard? But yeah, if it's a FLT3 ITD mutated patient who did well during induction, I would think about transplant and potentially post-transplant maintenance based on available data.
I think I saw it nodding from my team. So I think all of us at Cornell would nod and agree with that. And what if though, so we've been talking FLT3, we've been talking IDH, we have positive feelings now about these things. We feel like we have drugs that work, that get patients into remission, we might have post-remission options. What if this patient not only had at presentation those myelodysplasia related changes, but a complex karyotype to go with it? And you don't have your TP53 back yet because that's taking 2 weeks in your labs, but it's got a complex karyotype, she's got high white count, she could handle anything that you want to give her. How are we going to make the decision of what to do for that patient? Pinkel, maybe you want to comment.
So we know that patients who have a complex karyotype, they tend to be chemotherapy resistant or not as chemotherapy sensitive as we would want them to be. So in such a patient, while we're waiting for TP53, I would favor HMA and Venetoclax-based induction therapy, because we know that combination, based on the phase 2 and 3 data, that we have CR rates in the range of 67-70%, which we've never achieved from intensive chemotherapy in people who have a complex karyotype, where we can at the most achieve, with 7 and 3 at 30%, and with the liposomal regimen, a CR rate of somewhere about 47%. So I think that the CR rates with complex karyotype with the Venetoclax-based regimen is still higher, and moreover, the MRD rates after such a regimen are also not small. So I would prefer a Venetoclax-based regimen for such a patient.